Yo, what's going on? So to continue our discussion on antihypertensives, we talked about a couple of things. Last time we talked about ACEs and ARBs, and we talked about thiazides in the context of being an antihypertensive drug. So now we're going to talk about the rest of the antihypertensives, and I'm going to try to get them through this fast because last time it was a 20-minute video, so I'm not trying to do that this time. Okay, so the ACEs and ARBs that we talked about, they work through the kidney, okay, and that's how they have their antihypertensive effects. Okay, so but this time we're going to talk about other mechanisms of how we can decrease blood pressure, and that's through the blood vessels themselves, the heart, or the nerve. All right, so honorable mention though with drugs that affect the kidney is a drug called aliskiren. It's a renin inhibitor, and the ren here should help you remember that. And as far as adverse effects go, it's going to be the same as ACEs and ARBs, hyperkalemia, and everything associated. But then this time we're going to have increased stroke. So if a patient is on a regimen, aliskiren is part of that. They happen to experience a stroke. What drug was the most likely? It's going to be aliskiren. Okay, because the other drugs that we talked about, ACEs and ARBs, do not have that risk. Anyways, to get into a discussion about the other drugs that we're trying to get through for this video, so we got drugs that work on the blood vessels. This is going to be our calcium channel blockers, and these have the suffix pine or pine cone. So the cone can help you calcium, right? So pine cone, C for calcium. And then we have our alpha-1 agonists, and these are going to have the suffix zosine. So like prazosin would be another one. We're going to have drugs that work in the heart. So we got beta blockers, which have the suffix lol or olol, like propranolol, metoprolol. And then in the nerve, we have our centrally acting alpha-2 agonists, like clonidine and methyl-dopa. And these are really important for something that we're going to talk about in a second. All right. So mechanisms, as always, our calcium channel blockers, guess what? They block calcium channels. And so what? The thing about that is that if you block the calcium channel, you prevent smooth muscle contraction. If you prevent smooth muscle contraction, blood vessels stay dilated, and that's the way that we can decrease the blood pressure. The thing about zosins, so again, zosins work or prazosin, alpha-1 agonists, they work in the blood vessel by doing what? They work on the alpha-1 receptor, they agonize the alpha-1 receptor, and that leads to smooth muscle relaxation, okay? And then the intended effect here, the desired effect, is that they decrease total peripheral resistance. So that's what we're moving on. That's the desired effect there. For beta blockers, guess what? They block beta adrenergic receptors. And what is that going to do? That's going to decrease cardiac output and decrease total peripheral resistance. Why does that have our desired effect of decreasing blood pressure? Because if you decrease cardiac output, then the blood pressure will decrease. Okay, and something else that you should keep in mind, calcium channel blockers, beta blockers are mostly antiarrhythmic drugs. So they have other properties mainly that the drugs might be indicated for, but another indication is also hypertension. And so with our centrally acting alpha-2 agonists, guess what? They're centrally acting, they work in the central nervous system, right? And the gist here is that centrally acting alpha-2 agonists inhibit norepinephrine release. Norepinephrine is a vasoconstrictor, and so they act on the alpha-2 receptor in the nerve terminal, okay? An example of centrally acting alpha-2 agonist is clonidine and methyl-dopa, okay? Honorable mention here is hydralazine. The thing about hydralazine is that it's a direct nitric oxide releaser. Nitric oxide is something that the body uses to vasodilate. So the thing here is that there can't be like one single hormone or something that the body can produce to vasodilate everything, because there's just too much blood vessels. So the way that we do that is through nitric oxide. And the mechanism behind that is that it increases cyclic GMP. Okay, as always, adverse effects. Remember, calcium channel blockers and all these kinds of things are antiarrhythmic drugs. They work in the heart, right? So with calcium channel blockers, depression of the SA node. bradycardia, because again, the drug here is working on blood vessels, but the drug mainly works in the heart, right? It's also an antiarrhythmic drug. Bradycardia, SA nodal arrest. And then you have your more general adverse effects, general symptoms, GI upset, constipation, reflex tachycardia, and peripheral edema. But why reflex tachycardia? Imagine if you were to have massive vasodilation. What would that do to your blood pressure? Your blood pressure would tank, right? And so the compensatory effect here is to increase the heart rate to maintain blood pressure. Beta blockers. Big one here, impotence. If you have a patient that has sexual dysfunction, that is unable to achieve an erection, and they're on hypertensive medication, they're on arrhythmic medication, they're on beta blockers, that's the one. It's gonna be a beta blocker. And remember, these have the suffix olol or lol. Impotence, bradycardia, obviously, fatigue, exercise intolerance, postural hypertension. Okay, postural hypertension basically means that when you're in a sitting position and you stand, your blood pressure decreases. With our centrally acting alpha-2, remember, if you have a drug that's working in the central nervous system, you probably gotta have sedation, right? Orthostatic hypotension. Orthostatic hypotension means that when you go from a laying down to a standing up position, then your blood pressure will fall. And then finally, with our alpha-1s, our alpha-1 agonists, postural hypotension again. And remember, these have the suffix zosin. When you're thinking about alpha-1 agonists, you should be thinking about BPH, benign prostatic hyperplasia. It's a big one that they like to use. Prazosin is the one there. Now, big one for the big one for antihypertensive drugs that are safe in pregnancy, we have this mnemonic right here: new moms love hugs. Nifedipine, methyldopa, labetalol, and hydralazine. But clonidine is safe in pregnancy too. So new moms love hugs. So you know that if a patient is pregnant and they're having a hypertensive emergency, or they have preeclampsia, eclampsia, something like this, what drugs are safe to give? The drugs that are safe to give are labetalol, hydralazine, nifedipine, methyldopa. Remember, what's a drug that is not safe to give to a pregnant patient? ACE inhibitors and ARBs. Okay, so what about when to give what drug and at what time? Okay, so when we're talking about first-line drugs for hypertension, thiazides are always going to be first for Black patients and for non-Black patients. For non-Black patients, then you're going to go to ACE, ARBs, calcium channel blockers. With Black patients, you're skipping right to calcium channel blockers. And remember, this is in the context that neither one of these groups of patients have comorbidities, because then things change. Patient has diabetes, you're skipping thiazides directly, you're moving on to ACEs and ARBs, calcium channel blockers. The rationale here is that there are complications that arise with the kidney later on in the progression of diabetes, so you probably just want to leave that for last. So ACE, ARBs, calcium channel blockers. With chronic kidney disease, forget about thiazides, you're moving on to ACEs and ARBs. And that's it. If you like this video, thanks.